Thanks, Lorenza. Thanks a lot, Paolo, for this invitation, and it's a great pleasure to be here. Beside the fact that it's a phenomenal venue, also it's very interesting to me having the possibility to interact with the European level of the patient representatives is so key, so important for us as clinicians. So I think that everything has been already said by who already spoke before me, and in particular by Lorenza. She was absolutely super clear. Let me give you a more surgical perspective, and a little bit different in a way from the point of view of the key issue for those patients that face a potential for surgery. Now, next slide. Why a couple of basic points. You wanted me to go ahead because I will be probably much quicker if I do it from here. Oh, phenomenal. So just a few key points that may be relevant from the surgical point of view. Numerosity. Cholangiocarcinoma, the biliary tract cancer, are relatively rare. If compare, for example, to breast cancer, to colorectal cancer, we are speaking about in Italy no more than 1,000, 2,000 operations per year. So this relative few number is a negative drawback in a sense, in the sense that if you don't have a centralization of the activities, you have a dispersion of quality, competencies, there is such a different kind of approach in the whole country, and this is what is happening in Italy. We don't have centers of reference like is, for example, in UK. In UK, there are basically 7 centers where all the patients with cholangiocarcinoma are referred to. So there is a very nice centralization, and I heard that also in France is a big problem. And when a disease is relatively rare, that may represent a fundamental issue. And let me go ahead and explain you further in this setting. The second fact is that surgery of cholangiocarcinoma is super complex. Let me tell you, I'm an old surgeon. I'm doing this work in the last 35 years. I've been starting neurosurgery, then going a little bit of cardiac surgery, thoracic surgery, and now liver transplantation and hepatobiliary. Let me tell you that I've never seen a more complex intervention more than perihilar cholangiocarcinoma. Why? Because we are dealing with 1 square centimeter in the center of the liver, which is super rich of very important vascular and biliary structures, which are vital for the patients, and you need to be able to manage to reconstruct just in case, and to respect. And this is not banal, and after, I would say, in my personal experience, even though I do very huge number of cases, I feel myself as mature to face these patients only in the last 5 to 10 years, not more than that. So this is not something that can be faced in every single surgical center, and I would say not in every single hepatobiliary center. You really need to have high volumes. You really need to have in your hands reconstruction, vascular reconstruction capabilities, and the potential of thinking to liver transplantation. Let me talk to you about this a little bit more. There is a second further complexity, which is preparation to surgery. Most cases, present with high bilirubin, and high bilirubin is something that is faced as an emergency in all gastroenterological settings, at least throughout Italy, and I think also throughout Europe. So the patient immediately is stented. In first level, second level, third level, hospital, doesn't matter, but the patient gets a stent, which is a big mistake. Why? Because high bilirubin is not an emergency. You can live with high bilirubin for a long time, so you don't need to have a first-line approach. And who does this not always is aware of what will follow, is not always the most expert, specialist, endoscopist, or radiologist in the world. And they often do not agree with the final treaters, surgeons or oncologists, where to drain, how to drain, which prosthesis, which materials, which pathway. And often, as a surgery center level, high volume, we work in Padua, so we receive patients from all over the country. We receive patients that has been badly drained as a first level in emergency setting. And this is a problem because when the cholangitis starts, then the whole process may be jeopardized. You may not start with chemotherapy, you may not go for an effective surgery. So, and then we go to the action of the charity in a second. The first things to do from the surgical perspective, do not create awareness in terms to do not drain the patient unless you are in a super specialized center, because that is the first step of a treating of a very complex disease. They may jeopardize the second and the further steps from the therapeutic point of view. For the fact that the resectability is low, so the possibility that the patient achieve a radical resection is low. But what is very important is not only the technical capability of the surgeon, but the capability to define whether the patient is resectable or not. We receive a huge amount of patients that has been considered not resectable, and they were actually, at the contrary, fully resectable. This is a major loss of therapeutic chances, So that's the reason why you need a centralization. Because if you are considered not resectable in a center which has not the volume, not the expertise, not even the thinking of which is focused on cholangiocarcinoma, you may lose your chance. And this awareness, sorry, because I'm really getting out from a flu, but and this really need to be distributed in terms of awareness to the community, and this is charity important. Final point is liver transplantation. Liver transplantation is now not only a far possibility, is a concrete possibility. In Italy, we have two relevant prospective trials, which are, leading by Padua, for perialar cholangiocarcinoma and intrahepatic cholangiocarcinoma, which are based not anymore on the classic Mayo approach you may resemble, radiotherapy, chemotherapy, and then transplantation, which is very aggressive to the patient. Now we treat only with, a neoadjuvant approach, GEM-CIS, Durva, and then if there is a stable response, then we go to transplantation. So we're doing really a huge number of patients offering this opportunity. But for example, if the patient got a biopsy, a transceliac biopsy, the patient is not anymore eligible. And what is happening frequently in a very first hospital, very first line hospital, what they do in order to verify the diagnosis, they do the biopsy. The patient loses the chance for a transplantation. You know what a severe kind of potential mistake is this? If you don't get an immediate centralization of the patient in very high quality centers, which include the potential for liver transplantation. So the last, I don't want to bother you, but just to try to transfer to you the relevance of this in the clinical practice, when we see a lot of patients that has been operated on, open and closed. Why? Because the surgeon is not really capable to face difficult situation, and they say, okay, the patient is not operable, which is even worse, because not only you consider the patient not resectable, but you do an operation that may jeopardize further intervention due to the adhesions and the manipulation of the hilum that is very difficult already to manage. You can imagine if you already have a previous operation on it. So very important, the centralization. We have pieces of evidence out there saying clearly that there is a difference in terms of survival according to the volume of the centers that is taking care of the patient. And this is, statistically sound. And so if you treat the patient in a center that is not volume consistent, then you lose potential for survival in terms of the patients. And importantly enough, this is also for cholangiocarcinoma, intrahepatic and perihilar cholangiocarcinoma. And I think it's even more important to have a very high level multidisciplinary oncologic setting to take the decision. In many instances now we have, in our definitive report, the case was discussed in the context of oncology multidisciplinary setting, okay, but who were the specialists? Oh, the surgeon was not an hepatobiliary surgeon, the oncologist was not a super expert in biliary tract oncologist, and so on and so forth. So that value of that, decision is basically zero if you don't have a very high quality and comprehensive all the fissure, including the liver transplant expert in the multidisciplinary. So we need to promote awareness of that in the community, in the patient community, before they take care, they are treated. Let me spend 1 minute of this concept. You know this guy. This is the Nobel Prize in 2000 and something, probably 5, and is an economy Nobel Prize winner. It's not a health system. Why? What did this guy? He created a nice speculation on what is really valuable in health systems, what is cost effective. So what he's claiming that is cost effective, what produces values for the patient, which is not valid because until that particular time, we were very focused on the clinician perspective, 5-year survival, recurrence-free survival, which may not be the same outcome metrics that care for the patients. Let me make an example. If you have a recurrence, but if you have a nice quality of life and a perfect performance status, maybe you care less to have a recurrence and you care more to have a good survival. This is just an example. So the clinical point or the clinician point of view is different from the patient point of view. What is important from Porter is that we focus our whole action to the value for the patients. And again, this is not valid. So when we need to create awareness to the community, we need, of course, to improve the equitable access to cure, and it is important for cholangiocarcinoma, as we said. We, as clinicians, can provide the quality of the outcomes of the different centers, how it matches the mortality post-transplantation, the mortality post-resection, the proportion of resectable patients, and so on and so forth. No, we can give you the metrics, but in the end, the satisfaction is something that is in the hand of the patients and the patient representatives. So what I'm really asking to the charities is to provide us with PREMs and PROMs. So the patient-reported experience metrics. How is your experience, not of the surgery, but the whole process? Who took care at the very beginning? How was the drainage? How fast did you have the care? How fast did you access to surgery? How was the post-operative care and so on, the process? For Porter, what is valuable in terms of money is the whole process and the quality from the patient perspective of the process, and which are the patient-reported outcome measures, what you consider to be the most relevant measures in order to be qualifying a center a good center or not. So we need from the charities this kind of pieces of information, and we try to solicit all this reporting from the patient representative in all fields, liver transplantation, hepatobiliary surgery, and so on and so forth. And guidelines are very much focused on this and will be focused on this in the future. So PREMs and PROMs in hepatobiliary and cholangiocarcinoma. Why are vital? Because they focus on patient experience, and we need to have your reporting. Otherwise, the clinician will be conditioned by the old kind of approaches. Also in defining the endpoint for producing the clinical trials. Now, in a couple of slides, which are the charity possibility, on my perspective, many of these have been already suggested. We need for each particular country to create altogether a list of center, high volume center, high quality HPB center, liver transplantation center, to centralize the care of the cholangiocarcinoma patients. Why we need to do it together? Because we can provide the outcome measure for each particular center, but you need to provide the measure related to the experience of the patient in that particular center. Because I may do, the highest number of cases per year, but in the end, if my organization is not a good one, the patient experience may be not good one, and you are the one that you are supposed to give us the feedback whether my center is a good one or not from the patient perspective. So we need to have a list of centers, expert in cholangiocarcinoma, and we need to provide the path for the patient to reach those particular centers with an equitable access. So we cannot think that in a country like Italy, we are going to have 20 centers for cholangiocarcinoma, too many, too dispersive. So we need 10 centers, no more than that, and France maybe similarly. In UK, 7 centers. Those centers need to be identified. The politics is not doing this. We need to do it together and to create awareness on this. And maybe we need to also be able to provide free surgical second opinions, maybe in a telematic way. And we need to promote this network in order to create easiness for the patient to have opinions, Because what is happening in my outpatient clinic is that the more wealthy, the more, educated people, they reach you because they can navigate on Google, they can, go around, they keep pieces of information. The less wealthy people or the less educated, they don't know it. And this is something that is not acceptable in 2025. We need to increase equitable access. Everybody is supposed to, have the possibility to choose in the best informed way possible. Second issue, I think the charity should propose and support traveling and stay for the patients and the families. Because if we don't want to disperse all over a country the centers, then we need to promote movements. And for rare disease, this is the only way to go. And so we need to support these travels. And I think that this is money expending, this needing support, energies, and also logistic assistance. And this is very important. We are very well aware for the liver transplantation experience. We have 20 liver transplant centers in Italy. People travel a lot, and so they are struggling and financially struggling in order to find, locations around the hospital for long stay close to the hospital. 3, pre- and post-operative kind of operative support is so relevant and I don't have time to show you evidences, but prehabilitation and post-habilitation are key for survival. If you are able to support prehabilitation in patients that are supposed to have a liver resection or a liver transplantation in the next 30 days, they are going to change radically the potential to survive the operation. And the mortality is reducing massively, in a statistically significant manner. Of course, it's not easy to support, the families in order to promote a prehabilitation. So the charity, I think, may have also the possible duty to increase the logistic of this prehabilitation, pre and post the intervention, and then psychological support and rehabilitation programs. 4, the classical post-operative support is clearly important because patients and families need logistic support and help, organizational post-dismission controls, movements and logistics for devices, for movements in case of blood tests, controls, because surgeries is a demanding surgery, is needing a tight contact with the center after hospitalization for a while, I would say 1 month, a few weeks. So this is costly for families, and you need to support these families to stay, to go up and forth, even not stay in the hospital, because the hospital can care only of the very short period. Let me give you, if I have 1 minute time, we are promoting robotic perialar cholangiocarcinoma resection, which I consider it was impossible 5 years ago. Now we are doing it in order to discharge early the patients. Why? Because the trauma is less, the recovery is greater, they can access to neoadjuvant therapy as soon as possible, and so on and so forth. But when you have these very short hospitalization times, then you need to have support in the post-operative periods, So the logistic around the hospital in the area or in the region is supposed to be strong enough to support these patients for at least a few weeks or 1 month. 5, post-operative actions. We need to have PREMS monitoring to identify critical issues. So how was your experience? How did you go? Where was a mistake? How was the relationship with the personnel in the hospital? So we need to have these feedbacks in order for the centers to improve. And I think the Charities should collect this data and give feedbacks to the center, high volume centers, in order to let them to improve more and more in their organization, their capability to provide services and health. And again, we need Charities in order to develop cholangiocarcinoma specific measurements, outcome measures, because outcome measures matters. How you measure results of a procedure, like a big complex procedure like cholangiocarcinoma, is so relevant for clinical trial, for cost definition, for policymaker understanding, for the future developments of that particular area. Metrics, we need to have helps from Charities in order to define together which are the metrics for the patients. I'm going to conclude and then push on policymakers. Lorenzo already gave us a few examples of this. We need national guidelines, and national guidelines that are in the direction of a more personalized kind of approach. Now, the whole medicine and oncologic medicine is in the direction of personalized medicine. So you cannot generalize too much what you have to do in every single patient. We need to together develop this in a methodologically sound way. Again, push the politicians to go in the direction of centralization. We need to ask all together that we need to have regulatory indications to have centralized, well-defined centers in every single country in Europe. And we can do this kind of networking and political and regulatory job also at the European level. I think is very important to do. And again, access to transplantation for selected cases need to be pushed in terms of awareness, in terms of capability, in terms of logistic support, and clarity who is doing what. And of course, charity-funded registries are also important. Now, the federate learning is the best way for the future to go. So not to create centralized registries, but all centers could maintain their own registry and put it in an artificial intelligence setting, saving all the privacy kind of aspect. And I think we need to have support from charity in that particular direction. Last not least, support the HPV centers. Clinical trials. Lorenzo already gave you phenomenal examples. But surgery, more than the oncologic drugs, need this kind of support. Why? Because we don't have industries behind our shoulders in order to push our research. So in the last 20 years, we have living an imbalance between the capability to produce evidences in the oncologic, pharmacological setting, which has been promoted with a lot of money put by industry. On the contrary, the surgical area has been, not pushed in the same way. So even though you have relevant therapeutic tools in your hands, you're not able to produce evidences because you don't have that particular industry support. And surgery and liver transplantation are, lacking this kind of support. And charity may be so relevant in helping us in order to produce evidences. And, advanced devices, robotics, intraoperative tools. I was chatting with Lorenzo about the possibility that there is a study, a European study now ongoing, that the stenting with a particular material, with a particular kind of positioning is associated to 0% cholangitis. Can you imagine how this is policy changing, is dramatically changing the story of all these patients for chemotherapy, for potential for surgery and so on. And then surgical training, we have a dramatic loss of vocation. We don't have any more surgeon. There's no surgeon in Germany, a little bit less crisis in France, but big crisis in Italy. UK is borderline now. So this is going to be the future. You're not going to have any more surgeon. Why? Because this kind of surgery is super tough. For a perihilar cholangiocarcinoma, you need not less than 10 good, solid, hard hours of work. For a single surgeon, super expert, not a young guy. So we need to have support for this young surgeon in order to be motivated and to be following their teaching career. And then conclusions. Everything has already been said. I think that you guys can really impact all the phases of the patient path and journey. And my priority are to improve access to quality centers, to enhance the surgical outcomes, to better understand what really cares from the patient perspective in terms of outcomes. Not only survival, of course, survival is fundamental, but what else around it? Quality of life, prolonged, social life activity, and so on and so forth. And support the family and the patients, and I would say promote research, which is going to be also technically driven research, surgery-driven, focused research, not only oncology. Of course, oncology is super important. It's doing phenomenal, step forward. But surgery is still the best way to treat cholangiocarcinoma. So we need to have support in this direction. Thank you very much for your attention.
Thank you. I'm Helen Morment from AMMF in the UK. One comment. We don't have 7 centres of cholangiocarcinoma surgery. I do wish we had. They're liver transplant centres. We've just got transplantation for cholangio, very limited eligibility rules, but we do want centres of expertise for the care of patients. And then one question for you and Lorenzo, because I saw you sort of nodding to what Dr. Cillo had said. The first thing was a comment about we do not have specialist centres in the UK. I wish we had. They're transplant centres. And actually, transplant surgery is very different to a resection or a Whipple's. Some surgeons I've spoken to said liver transplant is easier than a resection for cholangio. You might agree or disagree. My other comment was a question, really. Why, if somebody has a biopsy carried out, can they then not have a transplant? Because actually, people would probably have a biopsy before their case is considered, and transplant might be on the table. So that might lose a lot of people the chance of a transplant.
Exactly.
That's it.
Sure. Well, probably I'm mistaken. I thought there were 7 big HPB centers.
There are, but they're not cholangio specialist centers.
Okay.
And people do not get referred to them when they have cholangiocarcinoma.
All right. Come on. Yeah. This is something new to me, but it's much better to be referred to a big, high-volume HPB. No, if I may say.
Sorry.
Of course, HPB center may not be super specialistic and super specialized in cholangio, but it's much better to be referred to an HPB center than to a general surgery. It's a little bit.
The majority of our cholangio patients don't get referred.
So we have a common problem to solve, and this is dramatic. I thought UK was. Now UK is a little bit back, in a way, a little bit conservative, if I may say, in terms of the indication to liver transplantation. Italy is a little bit more aggressive, has been more aggressive historically in transplant oncology, generally speaking, and that's the reason why we're promoting a number of prospective trials. So it's an area in big evolution, but you will see very soon a big expansion of indication to transplantation in cholangiocarcinoma. Second question, why, when you have a biopsy, I was speaking about a a transceliac biopsy, when you do a classic radiologic biopsy, because there is a high risk of a spilling of cells, a seeding. So when you have a potential for seeding of cells, liver transplantation is forbidden. So, and this is so banal for a liver transplant surgeon, what is not the case for, I don't know, a first-line gastroenterologist. So they see the patient, there is a mass forming, they do a biopsy, they put a stent. Wrong, both, because you lose chances for transplantation, and maybe the positioning of the stent is not the best way to go and jeopardize the further steps. I don't know if it's a little bit clear.
So, yeah, you just said that we need to have more expert centers, and I think this is true in every country. Yeah. So I was wondering, is there like specific training during the training of the MDs to be specialized in hepatobiliary, especially surgeon? Like, do you train people that will take your place when like you'll finish your career? Yeah, no, I'm sorry, but just like how we can improve the creation of expert centers and expertise in biliary like surgery that is very complicated.
Very good question, thank you. This comes to there is a big debate within the surgical community, and we can elaborate a little bit more, but just very simplistically, volumes. How can I teach you how to operate on a cholangiocarcinoma if I operate 3 cases per year? Impossible. I do my 3 cases. Hopefully, everything is okay. I don't know. I am not able to transmit anything. So volume is key. We need to centralize. And through centralization, you have the possibility to share procedures, processes, vascular reconstructions, because a small proportion of these cases will need vascular reconstruction. So if you already have a small number of cases, small number of vascular reconstruction, at the end of the day, the capability to increase expertise in super complex kind of procedures is very low. At the end of the day, that's the reason why, to my knowledge, cholangiocarcinoma should be faced only, I'm saying something politically very disturbing, only in liver transplantation centers. Why? Because you do a lot of vascular reconstruction for clinical practice in liver transplantation. Then you can apply when you need it, also in a liver resection. And you're right, a liver resection for perianal cholangiocarcinoma is more complex than a liver transplantation, much more complex. But you need to have that kind of mental engrams, which are vascular reconstruction, to transfer in the liver resection setting where needed. Finally, we in PADO are pushing for educational path, which include HPB and transplantation. US, divided courses. You are a liver transplant, kidney transplant, which is silly to me, and then you are an HPB surgeon, totally different. Well, it's no sense, because liver transplantation now is most cases partial transplantation, so you do resection. Well, this is something that need to be organized, and of course, patient and charity need to push